Hi, welcome to Dusty's Corner, and today we're going to go over just the fine points of adenosine administration to the pediatric patient. And again, this is not going over the pharmacokinetics. This is actually once you've got the right order, the right patient, all the patient 5 rights, and now we need to give adenosine. So a couple of things to keep in mind. Number one, your patient may or may not be coherent and responsive, and if they are, you need to make sure that you explained to little Johnny that this is going to make him feel funny, and get mom to hold his hand or caretaker to hold his hand, but explain to him that it's going to make him feel funny, but it's just going to be very quick, so he'll know not to be too surprised at what's coming. If this is an infant, it is very, very important to explain to mom that the medication may also make him feel funny. He may get quiet, he may scream. Just let her know what's coming, because oftentimes they'll go flaccid for a few seconds and then come back with this scream. And if you haven't warned mom or the caretaker what's coming, it can be pretty harrowing. So definitely explain to them what's coming. And when you're getting your equipment ready, always use lure lock syringes, because you're going to be pushing hard and fast, and if it's not locked into your stopcock, it could pop right out. And so make sure you have that. It's the only drug on the pharmacopoeia that you are absolutely slamming in. Most medications, even epinephrine, you push fast, etc. But this is one drug that you're moving hard and fast, so you have to make sure that it is absolutely airless. So just a quick little reminder about that. If this is an infant, he might have a PFO, a patent foramen ovale. He has an opening in his atrium. He could be an older child with an undiagnosed ASD. And if you have air in the system, you are transiently changing the intraatrial pressures in the heart. And when you go to slam that medication in, if there is air there, you can cause a right to left shunt and actually cause a CVA to your patient. So make sure it's an absolute airless system. Another thing to keep in mind, if this is a small baby, oftentimes that first dose is such a small amount that it will not clear the catheter, may not even clear the stopcock. So I just kind of want to demonstrate. Let's say, for example, this is a 5-kilo baby, and we know our dose for adenosine is 0.5 milligrams, which happens to be 0.167 mLs in a syringe. So watch when I shoot this exactly how far that 1.6 cc goes. Notice how most of it is still in the stopcock. This is why it is not surprising that your first drug dose that you give in a small infant oftentimes will not work. It's the second dose with a larger volume that actually gets there and clears the patient. So once you've attached this to your patient and it's airless setup, you have your saline over here, you have your adenosine here. Notice that your 3-way stopcock is open to all ways. So before you get ready to push your adenosine, you're going to give your adenosine and then give your flush. Keep your thumb on the bevel of your flush here so you don't have any backwash. And as noted before, you want lure locks to make sure this is really tight, because you're going to be moving hard and fast. And it literally always make sure that they're on a 12 lead or at least a rhythm strip, because you've got to see what's the underlying rhythm once you give your adenosine. And you've already prepped the patient and the parent, and everyone knows what's going on, and the patient is well monitored. And then at the count of the team leader, we're going to give this adenosine 1, 2, 3, and it literally is that fast.